All right, so what I alluded to today is we're going to talk about some, actually it's an older drug, but it is relatively new to EMS. And the drug we're going to talk about today is Tranexamic Acid, or more commonly known as TXA. Has anyone heard of this? This is the first time you're hearing about this drug and this protocol. It has been around since probably the 1950s, and it's been used on and off for a lot of different conditions, but never really got a lot of traction or consistent usage. And recently, some international groups and the U.S. military had been looking at this older drug a little closer and came up with some data that, and the data is not even that new. I mean, it's probably at least a decade or two old, but the EMS community has started to pick up and subdivide some of the results and look at it for more specific indications. And there's a growing consensus amongst EMS medical directors that this is potentially a very useful drug in the pre-hospital setting. So let me explain what we're going to be talking about here. So specifically, we're talking about TXA in the setting of hemorrhagic shock. So these are your sickest trauma patients. These are the people who have lost a significant amount of blood and obviously require transport to the trauma center, and presumably are either going to need transfusions or emergency surgery. As everyone knows, in trauma, the most immediate cause of death, I'm going to try to make this interactive, guys, so as much as possible. I don't like to just sit up here and read slides to you. I want to kind of get you involved. So feel free to stop me, ask questions. I don't mind interruptions at all. So when we look at trauma, there's basically 3 phases of death in trauma. There's the immediate phase. These are the folks who are essentially DOA. You arrive and they've died. What are the, off the top of your head, why do people die from trauma? Immediate causes of death. When you come up on a scene and you say, he's dead. Okay, so massive immediate hemorrhage. What else? So CNS. So massive blunt trauma to the head. So that's number 1. Number 2 is exsanguination on scene. So those are your 2. And then kind of not as immediate, but can also cause death prior to your arrival could be what? Airway. Perfect. Yeah, so airway. So those in that order. So massive head trauma, exsanguination, loss of airway. Nothing you can do about massive head trauma when you roll up on the scene. Nothing you can do if they bled out when they get on scene. Airway, obviously, if you arrive in time, you can intervene. The second phase of death is a little bit more complicated, but pretty obvious. Uncontrolled hemorrhage. So you arrive on scene and the patient is, maybe they're altered, maybe they're alert, their blood pressure is getting soft, it's dropping, they have obvious a bleeding. So let's say they have a lower extremity injury and they're pumping out blood. Is there something you can do about that? Yeah, tourniquets. And what else? Before tourniquets, we were widely about direct pressure. Yeah, so those things. And then, of course, we talked about airway. So the secondary phase of death is, again, airway is kind of in between. It can be a cause of death before you arrive. It could be a cause of death once you arrive on scene. But then that secondary cause of death in trauma is something that we very much focus on, and that's exsanguination. And what can we do about that? Direct pressure, volume resuscitation, and then immediate transport. What we're going to talk about today is something else that may help as well. And then lastly, the third phase of death in trauma, once they've reached the hospital, It's not something that EMS typically thinks about, but it's very important to the trauma surgeons. So why do people die? Let's say you get them to the trauma center, but you get feedback on those patients. You find out they didn't make it. What are the causes of delayed death in trauma victims? Any thoughts?
I'm going to get to the surgery room.
Okay, so, and the complication of that being, again, exsanguination. They can have unrecognized bleeding and die later. And then a complication of uncontrolled bleeding is they get coagulopathies, meaning that there are proteins in your blood that help you control the bleeding and clotting cascade, and you can use up all those proteins. And then you can have what we call DIC, disseminated intravascular coagulopathy, which means that you lose control of your ability to clot, and you start bleeding essentially everywhere. And in spite of massive transfusions, these people bleed to death. It can also lead to multi-organ failure, kidneys, liver, and then they can die from that. And then lastly, a couple of days after a significant trauma, people can die of sepsis. So we like to think of trauma mortality in basically 3 phases. Number one, first stage, not much you can do about. Traditionally, EMS has been focused on that second stage of airway and controlling bleeding. And then that third stage had always been in kind of the realm of the trauma centers of preventing this secondary bleeding, coagulopathies, organ failure, and sepsis. And that had not traditionally been something that EMS had been thinking about. But now with TXA, there is one part of that we can, and that is the coagulopathy that happens with uncontrolled bleeding. And that's going to be the focus of this lecture for the most part. Okay, so this we've already talked about. I want to make a quick mention about limiting fluids, the concept of permissive hypotension. Are we familiar with that? You guys know what I'm talking about?
Allowing the blood pressure to remain low so that we don't have them bleed out.
Right. So that's the summary. And anyone want to venture as what the mechanism is of that?
IV fluids and stuff. Yeah.
So what is it about IV fluids that is potential harmful?
It doesn't carry oxygen.
Well, that's the number one reason. That's the best answer. So it doesn't carry oxygen. So what carries oxygen? Blood. So the best resuscitative fluid is whole blood. Yeah. Logistically, it's difficult. We're working on that. BSO is kind of a leader in that locally and they're gaining momentum, and they've shown success with that. But it's taken them a long time to do it. I mean, they've got a lot of attention about it recently, but it's taken them a long time and a lot of hard work to get here. So, and they're a very large agency with a lot of resources. So for some of the smaller departments, I wouldn't consider us small, but our resources are a little bit more limited compared to BSO. So ultimately, ideally, whole blood would be the answer. Yes. So IV fluids, normal saline, Ringer's lactate, don't carry oxygen. That's true. So it doesn't make it as good as blood. What else doesn't it do? Clotting factors, right. So when you lose blood, you're not just losing your oxygen carrying capacity, you're also losing all those proteins in blood that help you clot. And you're replacing it with salt water. So it only does one thing. It restores perfusion pressure, but it doesn't do anything about oxygen carrying capacity, and it doesn't replace clotting factors. So what happens when you use up all your clotting factors? You bleed out. Yeah, right. So all those small injuries that weren't causing you a lot of problems, that were maybe you bled for a few minutes, you formed a clot, there wasn't a lot of pressure behind it, it clotted off. You use up your clotting factors, and those areas start to ooze, and you start to bleed from every place. And that's what we call the coagulopathy that I mentioned about in the secondary causes of death. And then theoretically, overinfusing with normal saline or Ringer's lactate to increase perfusion pressure can also, in theory, I don't know that it's actually been proven, but dislodge the clots that are there. Meaning that, let's say you have a spleen injury and you have a laceration to the spleen, you start to form a clot, the blood pressure drops, there's not that much pressure behind the clot, and that clot is enough to plug that hole. And now you start to fill the body up with crystalloids, you raise the pressure, and it's enough, there's enough pressure behind that clot that pushes that clot off and you rebleed. Theoretical, but that may be real. But the thing that we know is true is what you mentioned, not having any clotting factors. But those three things are why intravenous normal saline and Ringer's lactate are not ideal pre-hospital resuscitative mechanisms for trauma that whole blood is. But if you can't get whole blood, what we'd like to do is prevent you from consuming all your clotting factors. So that's the concept of permissive hypotension, that if we allow you to have a lower blood pressure, meaning that we're not looking for normal blood pressure, we're not looking for 120/70, we might accept 90/50. The goal is to make sure that you're perfusing the brain. And how do we determine clinically in a pre-hospital setting whether you're perfusing the brain?
Mentation.
Mentation. So if the patient is awake, they're mentating relatively normally, and you have a little bit soft blood pressure, you can stop. So obviously, if they're fading out on you and they have a blood pressure of 50, you have to fix that. You have to perfuse the brain, because ultimately, what are we all? So we're cerebral perfusionists, right? So the main goal here is to make sure that there is oxygen flow to the brain. So if the brain is telling you that it's getting reasonable blood and oxygen flow, then we want to be careful about how much resuscitative fluid we give, because we don't want to cause a coagulopathy. And then lastly, of course, this we know, and we're very fortunate in this area that we have relatively easy access to 2 trauma centers. So, but the conditions that we operate here is not the normal conditions in the rest of the country. You know, in many parts of the country, EMS has to travel a significant distance to get to a high-level trauma center, so decisions have to be made about, you know, who needs to go to a trauma center and who's going to go to the closest hospital and emergency department. We don't have to make those decisions because the closest trauma centers are usually not much further than the closest hospital. Okay.
Can I ask one question?
Of course.
So with the resuscitation, there was discussion on whether we could use a Lucas or have to do manual compressions if the patient does go into cardiac arrest.
Okay, so that's a 2-part question. I'm going to approach it in 2 parts. So first of all, traumatic arrest. The whole concept of compressions is really for cardiac-induced arrest, ischemic arrest, arrhythmia arrest. What's the most common cause of arrest in a trauma victim? Anybody?
Volume loss?
Volume loss, right, of course. So compressions should not fix that problem. So that's why, and then there's what's a smaller but very important reason to have an arrest in a trauma patient?
Respiratory.
Well, respiratory leading to cardiac, yes. I was looking for something else, but yeah, that's true. Pneumothorax, tension pneumothorax, right? Something that you can reverse. So, but getting back to the most common cause of hemorrhagic arrest, hypovolemic arrest. So it's not a problem with the heart. It's not a problem with an arrhythmia with the heart. It's the problem with there's nothing for the pump to pump. So the pump's in good shape, and doing compressions is not going to get you the answer you're looking for, because there's nothing to move. That being said, so the chief's question has to do with Lucas versus manual in traumatic arrest. The short answer is I don't think it makes a difference. The longer answer is comes from the original indication from the manufacturer that said Lucas was contraindicated in traumatic arrest. I think that's where you're coming from, right? And
Well, it's a common question.
Right.
And so for them, it's no longer a contraindication, but I just want.
right, but originally the
Yeah,
manufacturer
yeah.
used to
But
say
I
that.
just wanted Cruz to hear from you.
Yeah,
that we
so,
can use it if-
yes. So, and there's been some concern from our local medical examiner's office that the Lucas device was causing injuries that their conclusion might have contributed to the death of the patient. I'm not sure I agree with their logic because these patients were in arrest to begin with. So I don't know how applying a device after the fact that the patient has already died has contributed to their death. So it doesn't make a lot of sense to me. So, but to answer the chief's question directly, do I think it's acceptable to apply a Lucas device in the setting of traumatic arrest? My answer is yes, you can do it. But with the understanding that it is a different mechanism of arrest than your traditional ischemic and arrhythmic cardiac arrest, and the likelihood of a good outcome is very, very low, because the answer is not compressions, the answer is replacement of blood. So with the exception of when there's a cardiac tamponade or a tension pneumothorax. So,
Yeah.
Any other questions on that?
So some area agencies are talking about not doing compressions with these trauma patients. But
So-
as of today, if our trauma patients go into cardiac arrest, we are doing compressions.
Yeah. So I think that's the traditional answer is yes. There is a difference between traumatic arrest that is witnessed by you and traumatic arrest that you come upon the scene and the patient's already in cardiac arrest. So if patient is in a significant car accident or any significant mechanism of trauma and you find them in cardiac arrest, the likelihood of resuscitation is as close to zero as you're going to get, with the exception being there's a reversible cause like a tension pneumothorax. So many protocols will have you decompress the chest, and if that doesn't work, then you're done. Trauma surgeons, however, will, if you have somebody who has a pulse and then loses a pulse, they will work those. Usually that's in the trauma resuscitation bay. You bring somebody in with a thready pulse, but but they have something. They have some blood pressure, and they lose it in the trauma resuscitation bay. Those, even though the likelihood for a good outcome is still low, those are people that the trauma surgeons will do heroic interventions like thoracotomies and clamping the aorta to try to stop blood loss, or decompressing the pericardial sac if that's appropriate. But as far as we're concerned, if you have a patient that had a pulse and loses their pulse in transport, the question is whether you start CPR. At this point, I think the answer is yes, you will. But again, understanding the likelihood of a good outcome is poor. Those are folks that whole blood may make a difference, but again, we're limited by logistics about the ability to do that. So.
Great, thank you.
Okay, so what is TXA? So I like to think of TXA as almost like the anti-TPA. You guys have all heard of TPA, right? We talk about strokes, you get a clot, it goes to the brain, we give you a drug that breaks up that clot. TXA doesn't make clots, but it prevents the body from breaking it down. So, without getting too much into detail of the whole clotting cascade, because I'm sure most of you have forgotten that, if not unintentionally, intentionally from paramedic school. You know, it's a very complex cascade, but in general, there are proteins that float around in your blood. There's a protein called plasminogen. It's in your blood normally, and it doesn't do anything, but it's there to be converted into another protein called plasmin. And the way it's converted is there's an enzyme called thrombin that takes plasminogen and takes plasminogen and turns it in fibrinogen. Sorry, I'm going to get my terms confused. Fibrinogen and turns it into fibrin. Fibrin is this kind of this wispy-looking, spider-webbish kind of looking. They'll describe it as a lattice protein that is the beginning of the clotting cascade. And then the platelets and everything will get stuck in it, and it's the beginning of a clot. There is another enzyme floating in the blood called plasminogen. So there's fibrinogen, and then there's plasminogen. Plasminogen, when it sees clots, turns into plasmin. I know there's a lot of terms here. And plasmin breaks down fibrin. And there's a great video that's coming up that's going to explain it. What TXA does is prevents the activation of plasminogen into plasmin. That process requires an amino acid called lysine, and TXA looks like lysine to these enzymes, but it doesn't have the same effect, so it blocks that binding site. So TXA, again, just to review, TXA doesn't make your body clot. It prevents your body from breaking clots down, which is important because there's this continued balance between making clot and breaking clot down. And in the face of massive trauma, you can use up all these enzymes and you can end up with an uncontrolled breakdown of clots, and you have this secondary bleeding and coagulopathy that I talked about, a couple of slides ago. See if we can activate that.
The World Health Organization estimates that 1.5 million people die from traumatic hemorrhage every single year. The publishers of the CRASH 2 study estimate that by using TXA, we could save 100,000 plus worldwide. Let's talk a little bit more about TXA and learn how it works. Because of its massive potential to save lives, TXA has been the subject of a lot of research recently. The authors in this GEMS article break down that research and make a great case for pre-hospital use of TXA. Let's talk about how TXA actually works. So there's a protein floating around our bloodstream. It's called fibrinogen. It's not activated, it's not doing anything, it's just floating around our bloodstream. When we start to bleed, thrombin is activated, and it converts that fibrinogen into something called fibrin. And as you can see by the spider web behind it, that's kind of what the structure of fibrin actually is. It's the structure where all the bugs get caught and it forms that clot, okay? So it looks like this under a microscope. So we see our red blood cells, we see platelets, and they're all getting caught in this structure, the fibrin structure. It's oftentimes referred to as a lattice structure. Just that cross-hatched wood lattice reminded somebody of this. All right, so another protein we need to talk about is plasminogen. Plasminogen is a glycoprotein that's, again, free-floating in our bloodstream. When the body starts to bleed, the epithelial cells inside of our blood vessels recognize that we're bleeding. They activate something called TPA. That's tissue plasminogen activator. They activate and convert that plasminogen into plasmin. That plasmin I like to refer to as an attack dog. It's there to attack and break down those clots. It's a process called endogenous fibrinolysis. Endogenous means it's something that's naturally occurring inside of your body. It's not affected by anything outside your body. It's all internal. It's an internal system. Fibrin, we just talked about, and then lysis is the breakdown of something. So fibrin, lysis, it's the breakdown of that lattice structure that we were just talking about. So the entire job of this is to create clots that are not getting out of control and forming DVTs and PEs, CVAs, etc., right? We don't want massive thrombus, all right? So that plasmin, just like this dog's tearing a pillow apart, tears that fibrin apart, and then it continues to clot on top of that, okay? Now, in massive trauma, sometimes we get hyperfibrinolysis, and hyperfibrinolysis creates an uncontrolled breakdown of those clots that we're trying to form in that massive hemorrhage. So the medication we need to use, it's called an antifibrinolytic, all right? It's a medication that stops that fibrinolysis. That's what it's designed for. Tranexamic acid is that medication. Just like you can see the dog trainer stopping this plasmin right here, this puppy, it stops that plasmin from attaching to that fibrin, so it can't get to those pillows, right, to that fibrin, and it can't tear that apart, right? So TXA's entire job is to prevent the breakdown of existing clots. It doesn't cause more clots. It prevents the breakdown of existing clots. So now that you understand how TXA actually works, be sure to read this article and get a good understanding as to why we, in the pre-hospital setting, should be using TXA. If you enjoyed this content and you want more, be sure to like and subscribe and join us for future videos.
That was a good explanation.
Yeah, so when I saw that, I thought, well, you know, he's going to do it better than I am. So I thought he did a great job. Any questions about how TXA works? Okay, so we're going to move on to, that's all the theory. You know, what do the studies show? And I'm going to preface this with a qualified statement. There's a lot of studies out there on TXA. Some of them are not great studies, and the data is mixed. So I don't want anyone to take away from this that TXA is a miracle drug that's going to save all your trauma patients. But the preponderance of the evidence, we think at this moment, shows that for a select group of patients, TXA has the ability to save lives. So it's not perfect. There's data that's mixed, but that's why we do the studies. And you just heard the theory about why we think it should work, and then I'm just going to review. So there are two major studies that people usually refer to. There's something called the CRASH-2 and the MATTERS study. CRASH-2 was basically the original one. It looked at a austere environment, mostly in third world countries. Wasn't the best study to compare with US EMS systems because the ability to get to high-level trauma care in many of these places is not the same as in the United States. But what they came up with was patients who got TXA had a lower death rate, and especially if you sifted through the data and you found the patients with the most severe injuries, and if they were given TXA, the faster the better. And we'll talk about the timing of giving TXA in a few moments. But it was not a perfect match to what we do here, but it showed when you teased out the information, you found some interesting findings. And the conclusion was that there is benefit to giving TXA early to severely injured trauma patients, and it decreases 30-day mortality. The other study that is often quoted is a military study. It was, I believe, during the Afghanistan war, and a little bit more relevant to what we do, because they did have access to high-level trauma care. The difference is that the time to transport in many of these and military casualties can be much longer than for us. But it too showed that TXA is effective, especially if given early. So you have to give it within 3 hours. If you give it after 3 hours of the injury, there is no benefit and the potential for harm. However, in a U.S. pre-hospital system, the likelihood of giving TXA 3 hours after the mechanism of injury is would be very unusual. I mean, the only thing I could think of would be some prolonged extrication. So, the nice thing about TXA is, one, it's been around a long time, so we know what the safety profile of TXA is. It's very safe. There had been some thoughts that maybe it promotes clots, that you can get DVTs and pulmonary emboli, and maybe even strokes. But most of the studies have shown that that's not the case. Severe trauma patients are at risk for those things anyway. They're immobilized. So when you actually control for the fact that these are badly injured patients, you find that giving TXA to these patients doesn't make them any more likely to get a pulmonary embolus than if they didn't get TXA. Yeah.
So would TXA be contraindicated in crush injuries where there would be a prolonged extrication or anything else?
So as long as we're going to get to the list of contraindications, but the only contraindication on timing is greater than 3 hours, not necessarily the mechanism of injury. So yeah, you can give it. When we get to the draft protocol, we'll talk about it. But just quickly, it's going to be adults. It's going to be less than 3 hours, preferably less than 1 hour, and non-pregnant, just because it hasn't really been studied there. So as I was saying, TXA, the safety profile in TXA is very good. It's not expensive, so it's not going to make Chief Witten unhappy. So it costs anywhere from $30 to $50 a vial, and our protocol is going to call for 2 vials. And importantly, it's easy to give. It doesn't require refrigeration. You just need an IV. You're going to mix it in 100 mLs of normal saline, and you're going to infuse it over 5 to 10 minutes. So by the time you get to the trauma center, it should be in. So safe, cheap, easy to use. Okay, I kind of alluded to this slide earlier. It's a little busy, but what they're basically saying here is the sooner you give TXA, the better the outcomes. Ideally, you would like to give it within 1 hour of the injury, which I think for us is not a problem. So, in rural areas, maybe that's a little bit more of an issue. But for us, we're obviously going to get on scene within a few minutes. By the time you establish an IV and mix up the drug, you should be able to get this in within an hour. So, and as I said before, it's effective between up to 3 hours. Anything past 3 hours, it seems to cause harm. So we don't want to give this for where there's a delay in somebody accessing EMS. As I mentioned, the 30-day mortality is best within 1 hour of injury, and as I also mentioned, it's most effective in the severely injured. So you don't really see a difference in minor injuries because their outcomes are going to be expected to be good anyway. So we're talking about the people who are in hemorrhagic shock. So blood pressure is less than 70 have the best benefit from this medication. Multiple authorities are starting to endorse the use of TXA in the pre-hospital setting. The military is using it. I said here's a statement from the ITLS recommending use of TXA. Again, they say for patients with the number they use is systolic blood pressure of less than 100, we're going to use the same. Heart rate greater than 110, but the more severely injured they are, the more likely it is to make a difference. Dosing. So the traditional dosing, and this is a little bit controversial, the traditional dosing of TXA is 1 gram given in a pre-hospital setting, followed by another gram at the trauma center, but both doses have to be given within 3 hours. So the second piece has always been the hard part. Trauma centers can be a little chaotic at times. It's a little bit different than their normal routine. Maybe that second dose doesn't get in 3 hours. That's a problem. So the question then became, what if we just gave both doses in the pre-hospital setting? Gave 2 grams up front. So several agencies around the country have started doing that. And is one better than the other? Well, up until recently, we didn't really know. But there was a study that did look at it a couple of years ago, and they found no difference in the mortality if EMS gave 2 grams up front versus 1 gram up front and another gram by the trauma center. And the adverse events were the same, PEs, DVTs, things like that. So the conclusion was, if the outcomes are the same, why don't we just do both doses up front, 2 grams up front, because it eliminates the possibility of the second dose not getting in on time or missed altogether. So that has become a consensus of medical directors in South Florida. Not every agency has moved to TXA down here yet, but there is momentum that I think most medical directors are either considering it or actually are in the process of training on it. I know BSO has implemented TXA several months ago. I mean, it was this year. It hasn't been that long. There are probably some other agencies that are training on it now. I don't know how many have gone to the 2 gram protocol yet, but this is where we've landed, is to go with the 2 gram rather than the traditional 1 gram. And again, this is just a slide saying what I just said. So the military has endorsed the 2 gram dosing. So there is experience with the 2 gram dosing out there. So this is going to be what our draft protocol is going to look like, unless I don't expect there to be much change. This is going to mirror very much what other agencies are doing. And I've implemented this at Lauderhill starting today. Okay. So they finished training on this. So it's going to be for adult patients greater than 16. So the 16 is picked just so we can match up with the adult trauma centers. So it has to be for hemorrhagic shock. This is not for undifferentiated shock. This doesn't work for septic shock. This doesn't work for neurogenic shock. This doesn't work for anaphylaxis. This doesn't work for dehydration. This is only for patients who are bleeding as the cause of their shock. Understood? Okay. So we're going to go with, if you have a systolic blood pressure of less than 70 or a systolic blood pressure of less than 90 with a heart rate of greater than 110. So we're looking for people who are significantly hypotensive. As I mentioned before, the mechanism of the trauma has to be less than 3 hours old, preferably 1 hour. As I mentioned, non-hemorrhagic shock, non-traumatic shock in pregnancy are contraindications. Our dosing is going to be 2 grams mixed with 100 mLs of normal saline, infused 5 to 10 minutes. Some places are doing it even faster than that. If you do it too fast, there is a risk that the TXA can cause some transient hypotension. So the number I picked was between 5 and 10 minutes. Right now, there is pediatric dosing out there, but to start with, I thought we would start with just adults just to see how it goes. So, side effects should be minimal. Most importantly, if you give it, document it, and report it. You know, when you turn this patient over to the trauma centers, make sure that they know that you've given them 2 grams of TXA, and they don't have to give another gram. Okay. Side note on TXA: there is a crash 3 study out there on TXA with head injury, and you may hear that there are other agencies that are using TXA for head injury. The data is a little softer, so we're going to hold off and just start for hemorrhagic shock before we consider it for head injuries. But I can tell you as a little bit of a preview that it seems to have some benefit in patients with what I would call moderate head injury. So patients with Glasgow's of over, I think it was 8. So, and it kind of makes sense. If you have severe head injury, you know, you have Glasgow of 3, 4, 5, there's not much TXA is going to do for you, because the reason you're dying isn't for the damage that's going to happen, which TXA is trying to prevent. It's from the damage that you already have. So we wouldn't expect to see a difference between TXA and traditional care for those severe head injured patients. In very, very minor head injuries, you know, the Glasgow's of 14, 15, you're going to do fine regardless. You know, you got, you know, those are your concussion patients. Maybe you'll have some post-concussive symptoms, but you're unlikely to die in whether you got TXA or not. What this data shows is that middle ground of patients who have intracerebral hemorrhage but are not critical, the TXA may help prevent expansion of that bleeding and worsening during their hospital stay. So there is some evidence for that. It's not as great evidence as the evidence for hemorrhagic shock, but you know, we might consider adding that to the protocol at a later date. We're just going to see how that plays out. You know, the sheriff's office has included head injury already. That's fine. We'll see how it goes. So, but I wanted to start relatively simple to get started with this new protocol, and if all goes well, we'll expand it with time. So, I think that's all I have. Any questions? Yeah.
Just one quick question. Going back to when we do pass on at the hospital, making sure that we forgot.
Well, we don't want them to give extra.
It would harm.
Yeah.
Okay.
Yeah. So we want 2. We don't want an overdose. So
2 is
yeah. So 2 is the number. So it is important to document and report. So that is a take-home message. Yes.
If we were on scene with BSO and they were administering blood, can we still use the TXA?
So excellent question. In fact, you should. So if you have hemorrhage, if BSO follows their protocol the way I think it's written, that if they're bad enough to need whole blood, then they're bad enough to need TXA. And actually it leads to a good point. The best outcomes with TXA are TXA with whole blood together. That's your best. If you don't have whole blood, then TXA is helpful, but to be sure, TXA and whole blood is even better. So, yeah, so if BSO is already administering whole blood, and yes, we encourage you to give TXA.
As far as like hanging bags, is it the priority just to hang a 100 bag if somebody's like, they look like they're a bad patient, and have it ready to go? Or is it better, like we usually say, like hang like a 500 bag, just when we're prepping, should we just have 100 bags set up and be ready to give that first? Or
well, I mean, you're probably more experienced with knowing the logistics than I am. It doesn't seem to me that it would take much to get this ready to go. It would probably 100 bag, pop in 2 vials of this stuff. I don't think it'll take you more than a minute or 2 to do, but if you think that there's some logistical and advantage to doing that, I kind of defer to the folks who actually are out there. But I don't think that it'll take long once you recognize that this patient is in hemorrhagic shock. I don't think it's going to take you long to prepare it and get it up and going.
Yeah, and we can discuss that, but we can't lose focus. Our priority is always rapid transport, number one, as well.
Right.
And then the same with that is because we're.
Remember, this is secondary to your primary concern is obviously airway and bleeding control, right? And then splinting if necessary, decompressing the chest if you believe it's appropriate, and then this. So obviously you have to get an IV to do this. It can be given IO, so you can and I encourage you to place IOs in serious trauma patients because it's fast. So, especially if somebody's in hemorrhagic shock, it can be difficult to get an IV placed. So,
Great.
other questions? Okay.
Thank you.